Hi, welcome back to the Bart's Cardiovascular Simulation Lab. I'm Dr. Khalid Barakat, Director of Cardiovascular Simulation at Bart's, and today what we're going to be showing you is some simulation-based DOPs. The next DOP that we're going to show you is temporary pacing wire insertion. The objective really of this video is to show you how simulation can be used for DOPs and to get an understanding of the difference between simulation-based DOPs and live DOPs. The disadvantage of simulation-based DOPs is, unlike in a real patient, you can't just run through the procedure and then discuss it with the patient. Often, to try and address the objectives of the assessment, we need to break down the DOP into its constituent parts so that each part can be assessed separately. So the first part of the temporary wire simulation DOP is going to be a simulated patient where the trainee is going to discuss the case and the need for a temporary wire with the patient. So we'll get started.
Hi Amanda, my name is Dr. Kyriacos Mouyis. I'm one of the cardiologists. I've just come to explain to you the procedure we're about to do. Is that okay?
Yes, that's okay, doctor, thank you.
Okay, so you came in after having suffered a collapse while you were outside. When you came into the emergency department, we found that you had a very slow and abnormally slow heart rate and rhythm. You're a bit better now, but you're still in an abnormally slow rhythm. So what we need to do is essentially deliver electrical stimulation to your heart to make sure that it beats faster. It doesn't cause you any symptoms, and it doesn't cause you any trouble overnight, essentially.
Okay.
So it's very likely you will need a pacemaker, but overnight what we're going to do is a procedure called the temporary pacing wire.
Okay.
What that involves in is putting in a wire through a big vein in the groin, and it goes all the way up into the heart, and it delivers the electrical stimulation your heart needs to beat faster, effectively. You're going to be awake for the whole procedure. We can give you something to relax you, but we're not aiming to put you to sleep. Okay, you're going to be lying on a flat table. There's going to be a big team looking after you. We're going to clean the area in your groin. We're going to use a local anesthetic to anesthetize the area to make sure it's not uncomfortable for you. Go into the vein, introduce the wire whilst taking some x-rays under x-ray guidance into the heart. Okay. Make sure it's in the right place, and then we'll use it to, as I said, deliver stimulation to the heart. Is that okay so far?
Yeah, that's okay. So you said I'm going to be awake. Will I feel anything?
No, we're going to, as I said, keep you sedated, so calm, give you local anesthetic in the area. When we go in, you shouldn't feel anything really.
All right.
Okay? And if you do, let us know.
Okay, I will.
The procedure shouldn't last more than an hour and a half, depending how things go, okay? Shouldn't be too long, but we'll keep talking to you throughout. Now, as with any procedure that we do, there's obviously some risks involved. Overall, this procedure is very safe. The severe complications are very rare. Common things you might experience is a bit of discomfort around the site where we put the wire in. As I said, we can give you local anesthetic for that. There might be a slight, some slight bleeding or oozing from the side that we can apply pressure to make sure it doesn't get too bad. Significant complications, as I said, are rare, probably less than 1%. What they include is significant bleeding or damage to the vessels in the groin. And then closer to the heart, there is a risk of going through the chambers of the heart, causing significant bleeding around the heart that can bleed into the sac around the heart and cause problems with your blood pressure and make you very unwell. Very rarely that happens. It may need some further procedures if that happens. Also, very rarely when we put the wire in, we can get dangerous rhythms in the heart that we may need to shock you out of.
Okay.
And as I said, there's going to be a big team looking after you and monitoring for those things. Is that okay? Do you have any other questions at all?
That's okay. How long will the wire stay in for?
So we're going to put the wire now to, as I said, keep you well overnight. The plan is to very likely insert a permanent pacemaker.
Okay.
We'll aim to do that as soon as we can, maybe tomorrow, day after tomorrow, if we need to observe you for any longer, if any other problems come up. We will not aim to keep this in more than 2 days, 3 days maximum.
All right, that's fine, doctor. Thank you.
Okay, great, thanks.
Hi Kyriacos, I think you're doing another simulation-based DOP today, so we're going to do temporary wire insertion. Can you tell me a bit about the patient? What have you found out?
Yeah, so the patient is a 75-year-old lady who had a collapse earlier today, presented to A&E, was found to be in complete heart block initially, but now is actually in a second-degree heart block. She's at present hemodynamically stable, but is feeling short of breath. No significant medical history except for hypertension. She's taking amlodipine for that, and she reports it's well controlled. She hasn't been into hospital recently otherwise.
Okay, and we're confident about the drug history. I mean, she's not on a beta blocker or...
She's not on a beta blocker or any other rate-limiting medications. No, never taken any of them.
And have we had bloods back yet?
She's had blood. She's got normal full blood count, normal platelets, and it's got normal clotting, and there's no electrolyte abnormalities either.
And what electrolyte abnormalities might cause an issue like this?
I think probably be looking at potassium, hyperkalemia, but also significant hypokalemia, but we'll also be checking for magnesium and calcium as well.
Okay, so if someone's come in with this history, will they need a permanent pacemaker?
So it's very likely she will end up with a permanent pacemaker. We've got evidence of a high-grade complete heart block essentially with a collapse. So, and judging by the patient's age and comorbidities, it's very likely she will need a permanent pacemaker.
So tell me about temporary pacing. Why are we going to put a temporary wire in here?
So we're going to put a temporary pacing wire to essentially ensure she's stable and she's got background pacing overnight or for the next day or two until we can organize a permanent pacing device.
Okay. And if you have a facility where they could do permanent pacing, presumably that will be your default?
Yeah, if we could do a permanent pacing therapy straight away, would be preferable.
Okay. And in terms of temporary pacing, what access sites are you going to go for?
So we need to use a large central vein. Essentially, we can either use the femoral vein. We can also do it by the internal jugular as well. It depends essentially on patient, not preference, but habitus or what is more accessible, and also the rate of complications differs between the two sites, so may make us choose one over the other.
So what are the issues between femoral venous pacing and internal jugular pacing?
So the femoral venous probably has a higher rate of infection, and it's probably less comfortable for the patient because they have to lie in bed and be flat for the duration of it. For the internal jugular, especially if we use ultrasound guidance, it can be more comfortable for the patient. It's also essentially a shorter distance to go through as well.
Okay, and thrombosis rates with the two, any difference?
I'm not sure, but I would imagine the jugular has a lower thrombosis.
Probably. I mean, if you look, it depends what you define as thrombosis rate. So if you look by ultrasound, you get thrombosis on the wire, whichever route you go into, but because they're immobile, as you mentioned, lying flat with a line in, that will increase that issue, won't it? The risk of that. Now, internal jugular, so you've got the right and the left internal jugular. Which would be your preference and why?
Usually the right jugular, because it's an easier route into the right ventricle.
Explain that to me.
So we don't have to navigate round the bend from the left internal jugular, turning round into the brachycephalic.
Okay.
And then coming round. Jugular is a shorter distance to go in, essentially.
Yeah, so the right internal jugular is much more like a gentle curve in, isn't it? Whereas you've got 2 or 3 bends to negotiate, so it gives you torque issues. Okay, brilliant. Right, Kyriacos, so you've got scrubbed and you've laid out your trolley. Can you tell me what's on the trolley?
Sure, yeah. So we've got an assortment of syringes, 5, 10, and 20 mils. Use that to administer local anesthetic, and we use it to when we're gaining access into the vessel as well to guide us. I've got 2 needles, an orange and a green needle, to administer local anesthetic to the area we want. I've got scissors and a clamp and some gauze.
Okay.
We've got our sheath here and a guide wire. Again, we're going to use that to gain access into the vessel, along with a introducer needle. A scalpel to make a small nick in the skin to facilitate going in with the dilator and the sheath.
Okay.
And obviously the temporary pacing wire here, and a drape for draping after we clean with the sticks.
And the temporary wires, what sizes do they come in then?
So they come in French. This is a 6 French. They come in bigger sizes as well. I think 7 as well, and up to 8.
And you can also get much thinner ones. So what's the advantage of the thicker ones?
Well, it's probably easier to torque them in. It offers more support when you go in, and probably harder to dislodge as well. Probably they're heavier, so there's more risk of causing damage.
Perforation. Yeah, that's right. Okay, very good. And you've got 2 electrode connectors there, haven't you? Mm-hmm. Red and black. So what are they? What do they refer to?
So we use them when we are going in. We can connect them to get a surface, or an ECG essentially, to show us when we get.
No, we're doing this with fluoro. But for capture, okay. But those 2 electrodes, they've got 2 electrodes on the tip of that wire, haven't they?
Yes, that's the anode and the cathode.
So which one's which, black and red, do you know?
So the black is the cathode, and the red is the anode.
Yeah, so negative and positive?
Negative and positive, yes.
So which one's the distal electrode, do you know?
So the distal one, I think, is the anode.
The black one.
The black
if you have a look at the black connector, see if there's any writing on there.
It says distal on it.
There you go.
And this, yes.
Brilliant. Okay. So I think the next thing we'll do is gain vascular access.
Sure. So I've set up my ultrasound machine. I've got the flat surface probe that's for vascular access. Drape the patient, put my cover on. So apply the probe onto the patient's neck, trying to identify the internal jugular vein. So I can see just there in the middle of my screen. It's not the clearest, but I can see there's a compressible structure there.
Okay.
I shall try and bring it into the center of the screen.
So why do you use the short axis view?
So the short axis view allows me to make sure that I can differentiate the vein from other vascular structures, such as the artery, which would be pulsatile and non-compressible. And it also allows me to basically try and keep the vessel in view the whole time, because from the long axis, if I lose my plane a bit, I won't be able to see the vessel at all. It might be more difficult to orient myself.
I think sort of. I think so. The short axis view will allow you to hit the top center of the vessel, which is what you're trying to do. In the long axis view, you're right. The rationale for trying to use that is try and keep the needle in plane all the time, but of course it can dip in and out, which can cause problems. So with the short axis, of course, you won't see the needle until it transects the imaging plane. So how do you counter that? How do you know that you're heading in the right direction? Well, how do you work around that issue?
So I would ensure that my needle goes in, I find the midpoint of the probe and go in that way, so I'm perpendicular to the ray, so I can keep an eye on the needle as well. Or I can go in and tilt the probe until I can see my needle and then know where I'm.
And then follow the tip through, is that, yeah?
Tip through into
okay.
the vessel.
And of course, if you do use the center approach, where you've just fixed the probe, you've got to get the vessel into the center.
Yes, center up the vessel.
All right.
So I can see the vein just there. I'll try and center it. It's just there into the center, in the center of our screen. I've got the needle with the syringe attached. Okay. So we're in the vessel now. I can see the tip of my needle just in.
Okay, good.
Trying to thread the wire in, getting good flashback.
So you're happy wire's gone in. Now how are you going to confirm all of that then?
So yeah, I'm just going to take my needle out and scan again
Good.
to make sure that. So I can see the wire going in.
Yeah. So that's in the short axis plane. I can see an echo bright spot right in the middle of the vessel. Good. Okay. Now how are you going to confirm that you've not gone out the back of the...
So I need to go in the long axis.
Okay. So
I can see the wire going in there. It's in the vessel. Try and follow it down if I can. I can see it's in the vessel there as well.
excellent. So Kyriacos, we very nicely demonstrated how to get into an internal jugular using an ultrasound. Having said that, we're going to do this from the left femoral approach.
Yep.
So with the left femoral approach, when you go up, what are the issues going up through the abdomen for the vein?
So we now have to, we're going to go in by the left femoral here, so we need to basically make sure we don't end up into other branches, because it's a bit longer distance compared to, as we described earlier, compared to the internal jugular.
Okay, and so if you come off at branches, they're usually at right angles to each other. So how do you negotiate getting up the inferior vena cava?
So we do have a 45 degree angle here, so we need to ensure that we pointing the right way and torquing and turning slightly to make sure we go straight up instead of to right angles.
Fine. Now what I've done is I've set the machine up so it's got auto track, which means it'll follow your wire up as you go. Okay, and it's in an AP position. All right, let's get on with that then.
There's my catheter going up. You can see it's going up the left femoral vein. Now we're joining up. I think now we're going into the IVC. Going up at the level of the heart.
So once you're in the right atrium, what are you trying to do in order to try and cross the valve?
So we need to be pointing towards the right direction. So it's going to try and get into the right atrium first.
I mean, sometimes coming up from the leg, if you've got enough of a hook on it, sometimes it'll naturally just fall through the tricuspid towards the apex, won't it, as you're coming up through the IVC. If it doesn't, then you're presumably trying to do what you're doing now, which is to do what?
So turning and torque towards the right direction and twisting.
So you're trying to get the right atrium to hook somewhere in the top of the right atrium, so the lead to hook somewhere in the right atrium, yeah? To cause a coil. And then your plan is to try and torque the wire when it's coiled up so that it prolapses through the tricuspid valve. So you keep entering the SVC, which is fine. So you're probing away, trying to find somewhere for it to hook up in the right atrium. Okay, good. Try there. There you go. So it seems to have just glanced across the tricuspid valve there, doesn't it? And when you cross the valve, what do you see?
So it should, so I cross the valve, I think I'm doing there.
Yeah, okay. You can sometimes see ectopics, can't you? You haven't seen any so
I
far.
haven't seen ectopics, still in the normal rhythm.
So where are you going to try and position the lead tip?
So I'll try and position it, I mean the options could be the apex or at the septum. So if I leave it at the apex, that would be a good position, but I'll probably run a slightly higher risk of puncturing through.
but it's probably going to be most stable at the apex.
Most stable at the apex, exactly, and
Yeah.
despite the higher risk.
So how are you going to try and manipulate that catheter down into the RV apex?
So I'm just going to try and rotate slightly so it drops down into the apex. So I'll try and do that now. I think I'm pointing there now. And pull back a tiny bit.
That's right. So it's a combination of torquing the catheter and pulling it back very slightly as you do, and then it drops down into the RV apex. Okay, that's brilliant. Stop fluorine there. So now once you've got a position that you're happy with, what are you going to do next?
So I need to ensure that we've got essentially capture.
Okay. So what are you going to do next then?
So now that our
connect
wire
it?
is in, we need to make sure that we can attach it to our pacing box. So I need to put on the attachments onto the ends here, both onto the distal one. Make sure they are quite tight.
Okay.
And onto the proximal one.
Great. Okay. Well, let's connect the box up and then you can talk me through doing a threshold.
Sure. So we've got our box here. First of all, we need to make sure that it's attached properly at both ends. So proximal end, that's attached and it's tight, and distal one again attached and it's tightly on. So I'm just gonna open this like that. First of all, we need to make sure that it is on. So flicked it on, I can see the lights flashing, pacing and battery. So on demand pacing, I'm just gonna adjust my rate. I'm gonna put the rate up to 60 or 70.
Fine, or whatever, but yep.
Start at 60. That's on. I can see pacing spikes, but there's no capture there. So I need to adjust my my output, my threshold essentially. If I increase that, still no capture. Okay.
So what are you seeing now?
Now I can see every pacing spike followed by a QRS complex. So we've got electrical capture.
Your consistent capture.
Consistent capture. And I'm gonna, that's about 4. I'm gonna just increase that a bit more to ensure that we've got a good sort of buffer for our capture and it's not gonna get lost if the threshold goes up. So I've taken that up a bit more.
Are you going to work out the threshold for me? So what's the threshold?
So the threshold is where we lose capture. If we go back down, still got capture there. So I can see I've lost capture just there. And that's at about 1.5.
Okay, so what's the threshold then?
Threshold is when we get the capture. So there I've got capture again, and that's at about 4. So the threshold is when we get the capture.
It's the minimum voltage in which we get consistent capture.
Exactly,
Yeah.
so that's
Okay.
about 4.
So it's quite high, that, isn't it?
Quite high, yeah.
So what would you do in that scenario?
So we could have a look, make sure the wire's in the right place. So I could go back and screen, make sure it's in the right place, essentially.
Okay. And if it, if it looks like that and you're happy it's stable, ideally you want it to be below 1, don't you?
Yes.
But you've got to make a trade-off in the middle of the night about protracting a procedure and the safety of the patient. So that's a decision you'll have to make. Okay. And then once you're happy with the threshold that you have, how do you secure these lines in?
So we need to make sure that we sort of curl up all the excess wire, and on its exit I'll probably suture it in. Use some technique, maybe it's like a mattress suture.
Okay, Mersilk maybe?
With a Mersil suture mattress, and then curl up the rest of it and make sure I sort of secure it there with enough sort of Tegaderm or something sticky.
Brilliant.